Good morning, everyone, and welcome to the Global Cancer Surveillance for Local Impact webinar, Leveraging Partnership for Data to Action. So it's the first webinar in the IARC at 60 series, celebrating 6 decades of cancer research for cancer prevention. So to open today's session, it's my pleasure to hand over to Dr. Freddie Bray, head of the Cancer Surveillance branch at IARC, who will introduce the theme of this webinar and our distinguished panel of speakers. Thank you.
Well, thank you so much, Yasmin, and thank you everyone that's taking part in this webinar. It's very nice to be here this morning, wherever you are. Hope you're doing well. So this is indeed on global cancer surveillance for local impact, and really trying to better understand how the cancer surveillance branch works, how cancer surveillance at the International Agency for Research works, and it's very much, as it suggests in the byline, about leveraging partnerships for data for action. So I'm going to go through some of the aspects to this, but just to give you a sort of rundown on how we're going to do this, I'm just going to give an overview of some of the aspects of the branch, and covering everything from the collection of the data in a quality assured manner through to the dissemination online. Les is going to pick up really what is foundational to our work, the support and development of the cancer data locally through population-based registries, and Isabelle will then speak to how we're really trying to use descriptive epidemiology and expand and evolve that long-standing research activity into one that's increasingly innovative. And with that, we have, of course, the three of us, but we really are joined by three stellar individuals in different domains in cancer surveillance, with Professor Giske Ursin from Norway. She's a cancer registry director and also professor at the University of Oslo. We have Mrs. Korir from Kenya. She's the senior researcher in KEMRI, the Kenyan Medical Research Institute. She's also the director of the Nairobi Cancer Registry. And we have, of course, Professor Canfell, who's the lead of the cervical cancer Elimination at the University of Sydney. And these are, as I said, stellar people, but brilliant collaborators over many, many decades. We really have chosen well in terms of the interview. So thank you so much to Giske and Karen for being involved in this webinar. I thought I'd try and take you through the sort of the who, what, why, where, and when of the agency in terms of cancer surveillance. So who we are in terms of IARC, based in Lyon in France, what we do in the context of cancer surveillance, why we do it, which I'm sure is obvious to many, where we work and how we go about it. So I thought I'd just start with that and try and do this in the next 15 minutes or so, and I will have a little interview with Giske at the end of this. But just to start with who we are, and it's kind of in the question. So let's get back to this, right? So the International Agency for Research on Cancer, I think everyone knows this is the Nouveau Centre as it was. We've been there since 2022, so we've been here for a while, but this is the new centre based in Lyon in France. But we are a specialised cancer agency of the World Health Organization. We were founded in 1965 through one of the World Health Assemblies. We're called semi-autonomous in that we are governed by our governing council of 30 participating states, and we have a scientific council that supports the scientific direction of our director and senior staff. Director, of course, being Dr. Elisabeth Weiderpass. So we have our 30 participating states, and you can see the flags. The most recent participating state joining was Saudi Arabia. You can see on the second to the right. But that reference point for cancer information really does come from our mandate from the World Health Assembly, from the 18th World Assembly in 1965, and that's precious to us. I mean, this is our mandate to freely distribute data and statistics based on very much partnerships and collaboration, particularly as you'll see with population-based cancer registries. And this mandate from WHO is important because it does enable us to go to country, it does enable us to work with regional offices as well as HQ and joint plan some of the activities around things like the signature initiatives of WHO and national cancer planning generally. So it's very important for us to have that link, that clear link with our parent organization, the World Health Organization. And then just on the what. So we're the Cancer Surveillance Branch. We're a small group, I guess. I mean, I always thought the back in the day when I started working cancer registration at the unit of descriptive epidemiology with Max Parkin, we'd have 200 people, but it was small then and it's small now. It's about 30 to 40 people maximum. And our key mission is to consolidate, expand IARC's role as a global reference for cancer data. So this is our own mission. And we sometimes think of these things in blocks, but they certainly aren't. I'll give a better description in a moment, but these are the key aspects that we do. There's a core foundational activities and accelerating cancer registry development and support through collaboration with registries worldwide. There's a development and expansion of cancer indicators across the cancer continuum, commonly online, but through our research work. And of course, there's research itself, descriptive studies in person, place, and time. But of course, we've always had a long-standing program in childhood cancer. And more recently, and as part of the last medium-term strategy, or the current one, we're evolving into the one from 2026 to 2030. But in any case, we're very interested in descriptive economics, trying to put dollar signs to some of the public health indicators we create, and also looking at the between and within inequalities as they pertain to cancer in countries. A better way to look at it, and this is the sort of way we try and instill how we talk to our staff and how we actually really work with cancer registries and develop indicators, conduct research, and make that available. It's really under this mission of expanding our role in global reference. Really, we're not actually working in silos here. It's very much a continuum with bi-directional movements around these three areas. So the principle is actually, this has got a bit unstuck, but the foundation is the high quality data that we have. And this comes very much from this support and collaboration of cancer registries. Without that, we cannot create global indicators of any semblance of quality. We do need to have the underlying data. We can't just make a mathematical representation of nothing. You do need to have local data. And the local data, of course, is inherently important for cancer control and cancer research on the ground for those countries. Similarly with research, we use the indicators, we use the registry data, but again, it has to be, the baseline has to be high quality. That way the research is considered not just innovative, but actually, it's correct and scientifically appropriate, and it leads to better funding and so forth in the future. And making that data available is through research, but also online. But it is a continuum, and when we make estimates, we try and make it quite clear that these are estimates, and sometimes we don't have the underlying data. So this principle of foundation, compilation, insights, and dissemination is critical, and it all comes under this banner of trying to build a global network, this idea of partnerships, and build capacity through registry support, training, consultancies and site visits. And it's a cycle of data and knowledge. It's very much a continuum. We're not working in one specific aspect. None of the staff, I believe, do. And this is really important to how we work. And then just on why we do this, I hope it's obvious. This is a Human Development Index. This is societal and economic change over 20, 30 years. We're all transitioning towards high levels of human development on the basis of income, education, life expectancy. But there's a clear indication between where we are with human development today and premature mortality and the types of cancer that are the leading causes the types of disease that are leading causes of premature mortality. You can see in light blue, this is where cardiovascular disease is first and cancer is second. In dark blue, cancer is first, cardiovascular disease is second. And then in most of sub-Saharan Africa, which is demarcated here, cardiovascular and cancer still in one of the two are in the top three, commonly cardiovascular disease, and there's other important syndemics, I guess, double burdens of infection still existing. But it's a transition. It's an epidemiologic transition, and cancer will become this dark blue color will become more and more apparent over the years, partly because cardiovascular disease, at least in relative terms, is more preventable and treatable than some cancers. Sorry, and then obviously there's a lot of variations, even at the 4-tier human development level, low, medium, high, and very high HDI. Very much combination of common cancers such as breast, prostate, and colorectal. Some specifics such as thyroid cancer, which is particularly high now in China and Brazil. But you have a sort of a long-standing burden related to infection and poverty-related cancers such as cervix, liver, and stomach cancer still there too. And it's important to think about premature mortality, and this is one paper, and it sort of links the research to what we present online. Even if productivity losses from premature cancer mortality linked to paid and unpaid work, that's probably 40% of the total. We're not even thinking here about the direct costs such as treatment and pharmaceuticals and diagnostics, but it's already 0.6% of the GDP. So losing people due to cancer has a huge impact on productivity, and includes some of those leading cancers you saw on the map there: lung, breast, and liver cancer. This is really important. And this is just the leading cancer in terms of total productivity loss in every country. You can see there's a lot of different cancers. Again, we need targeted cancer control, but as you can see, many of the main cancers are quite preventable, or at least treatable through timely diagnostics and treatment. And the other aspect, of course, is we know there's going to be a 75% increase in the cancer burden, largely through population aging and growth. Even if rates stay the same, or even if they decline, most of the largest increases are going to be seen in absolute terms in relative terms in the low and medium HDI countries, least equipped at the present time to afford this rising cancer patient population. Show you that one. Okay, and lastly, of course, we know it's quite critical, not just that there's a huge loss of productivity and life and burden and suffering due to cancer mortality before the age of 70. There's a deficit in the availability of the data. We know this very much in terms of the incidence and mortality. Putting it another way, 2 and 3 countries cannot report high quality incidence. 3 and 4 countries cannot report high quality mortality data. This is a jarring inequity in data, and this is really where we sort of come in the sense. I mean, we really must inform cancer control activities, inform cancer research by having data in every country of a robust nature. And presently we don't have that. And estimates are one thing, but we do need to really sort of work on the ground to provide the technical assistance. And this is why being part of WHO is so inherently important. And then where we work, well, we work everywhere. I mean, we really do work in 185 countries. We, of course, have our 30 participating states. And for example, in Egypt, we have a very cohesive program of work trying to develop a national cancer registry program as a participating state. And that's the case in every country. We have specific activities going on, but we have a mandate that's global. It's an altruistic notion of the agency anyway from its outset to support countries in transition. So we work in every country. This is cancer incidence in 5 continents perspective, a national perspective, just showing you where there's national coverage. Dark blue, light blue is regional coverage, and where that is the case, the red is the subnational registries where they exist. These are the ones of high quality. And even here you can see many countries in Africa, southern and Western Asia, and in Southeast Asia, such as Indonesia, very large countries where we don't have any data. And this is the big challenge that we face, as I've mentioned. The things we do to try and improve that situation and work with cancer registries as a sort of foundation, as I mentioned, is twofold. One is through the GICR. I'm not going to speak on that because Les is going to speak on exactly what that is, but we're also the secretariat since 1974 for the International Association of Cancer Registries, IARC. This is an umbrella organization of cancer registries worldwide, really about fostering exchange, but also the development of tools and standards, enhancing comparability between registries. And this is the sort of work that we do in these countries, across countries. And the key thing, and I showed you the map already, is cancer incidence in 5 continents, set up by Sir Richard Doll with the UICC back in the days when we used to speak of geographic pathology in the 1950s, but the first volume came out in the 1960s, and we really have been doing that and since the 3rd volume at IARC, and now we're in the 12th volume. The data is not exactly timely, but it's a good marker of the quality, and we're trying to enhance the timeliness through calls for aggregated data. But anyway, it gives us a good idea of where we are in terms of where we need to work in terms of data, but it also is absolutely inherent that we have this data because it's the basis for our estimates, not just the data that's accepted. And we have some 460 registries in 65 countries, 65 countries in CI5, but it's all the submissions from many other countries, over 100, that actually form the basis for the global CAN estimates. And there's a lot of variability. Anne is with us from Nairobi. It's one of the cancer registries included in the last volumes. Kudos to Anne and her colleagues. A lot of variability from volume to volume, though, and it's good at the moment for sub-Saharan Africa, but there's a lot of sustainability issues, not a lot of government buy-in, despite some clinical commitment, despite what we've seen about the cancer profiles and the increasing burden. And it's very different in different countries. This is just the registry is now accepted in China, 157, over 60% were accepted of the 250 odd submissions, but they have 3,800 registries in China, covering about 98% of the population. We expect many more registries to submit the data. So it's a changing paradigm. And we are changing in cancer registration as we are in many aspects of cancer control. We have, of course, the prospect of using AI and machine learning and natural learning models, large language models, etc., to advance the capture of information at the level of pathology at hospitals and so forth. This is quite critical. It's something that I think is global, but there's a very nice paper. It's one example from our SEER colleagues at the National Cancer Institute, looking at some of the aspects of how they're trying to do this in the US. I just mentioned some of the events that are ongoing. There's a kickoff meeting of the Cancer Watch, and I'll talk to Giske a little bit about this in a moment. This is a joint action supported by the European Commission, really trying to improve the cancer data going into the European Cancer Information System, really trying to bring cancer registry data up to speed in terms of timeliness and quality. And juxtaposing that, I guess, is a visit I made in last couple of weeks. It was 2 weeks ago. I was in Nigeria, in Lagos, Abuja, the capital, as well as Kano, which is in the north. 20 million population, expanded a lot, and they're trying to develop a population-based registry, very rudimentary, just starting now, very challenging infrastructure and circumstances to work in. So we're all in very different places, but we want to work with all colleagues around the world. This is what the International Association is about, and whatever's good in the highest income countries will hopefully come available to transitioning countries as well, including the prospects of AI. And Les will speak about DHS too, the prospects of actually using that to leverage some of the paper-based records through to sort of having this automated. Just a shout to the meeting. It's less than 6 days now. It's a week away. We're going to have our IARC conference in Izmir. We're going to talk about AI in a workshop with our Netherlands colleagues, led by Heis and others, who are going to talk about some of the ways we can use AI to leverage opportunities in registration. Let's see what I'm doing for time. It's a couple more minutes from me, and then we'll go to Giske. So the how, well, we're going to hear from Les on how we ensure high quality data. That's the sort of foundation, and we're going to get some insights from Isabelle on how we go about conducting research. Maybe I'll just end on something more about the indicators and how it works. I mean, the Global Cancer Observatory has been I think a big success once it was launched. It's almost 10 years, 2016. This is a sort of, we've tried to sort of develop not just a repository of data, but something that is very much user-friendly and links back, we hope, and it's probably not as apparent as we like, back to the cancer data and the importance of having the local data. Like I said, we're not interested in making a mathematical representation of reality when reality means that 3 and 4 or 2 and 3 countries cannot provide data of high quality. I mean, this is something we need to push for, but nevertheless, our mandate is to support these estimates, and we do this through Cancer Today. But there is this link between the research is absolutely critical. There's different ways to disseminate. This is one example. These are the highly cited papers that are part of the CA Cancer Journal for Clinicians. This is one example, but you know, these papers are important. I'm not suggesting this is anything to do with myself or indeed perhaps the branch, but it shows the importance of these sort of reports in the context of how important cancer is. It's often a first reference in the first paragraph of papers, but nevertheless, they're among the top 10 cited papers in this century. These last ones for 2018 and 2020, the Global Can estimates. So cancer is incredibly important, and I mentioned already some of the work on productivity loss. I think Isabelle will mention this again. It's a paper recently in JNCI, but there's a whole website dedicated to this and the cancer impact. There's also the cervical cancer elimination with Karen, and Isabelle will speak about that as well. There's papers on cancer causes. This is the most recent one from Oliver, one of our master students about to have his PhD viva. This is on melanoma incidence and UV, but this is again, it's a website that's available. People can peruse a lot more than just what's in the paper, and that's being updated at the present time. So lastly, I mean, we can be sanguine about the ideas that we can estimate exactly how many cases are occurring in terms of cancer incidence, mortality, and the number of people living with the disease within a time period down to single digits. But the reality is we have to be cognizant of the fact that it's a process, and we want to get away from these linear blocks. It's very much interdependent on improving medical records and systems in hospitals, etc., improving cancer registries worldwide, ensuring they're sustainable, and there's threats on every level of income and development level, which we may touch on with Giske. And you know, we can get the burden estimates, but it's a cyclical function, and unless we get high quality data that's available for local cancer control and cancer research, there's no point really making these estimates at all. Okay, and I think I'm more or less done. Yeah, and I think it's more or less my last slide. This is the African Cancer Registry Network, which is flourishing under Max and Ying coordinating, but we have the collaborating centers, one of which is with Anne in Kenya, one is with Masvita in South Africa, and another in Cote d'Ivoire with Franck and Guy, and you know, really we're trying to sort of develop and set up registries in Africa based on sort of collaboration and support of satellite centers, call them centers of expertise in the continent. And if we can flourish the registries for cancer control and reducing the burden and suffering through informed data, then we can actually also make better estimates as well. And that's the general principle. Our ideas are to provide technical assistance, consultancies, provide networking opportunities, advocate the cause of cancer registration, to support cancer control efforts, to support better data globally and locally. That's the principle of how we work, and we really want to make this whole map blue in the next years. That should be our main objective. So I'm gonna stop there. Now I may stop sharing my slides if I can. Do that, and then I'm just going to turn to Professor Ursin. Professor Ursin is there, wonderful, and thank you again. I've been running through that very quickly, but thanks again, Giske, for being part of this webinar. And I just wanted to ask you a few things, and I know you've got a lot of experience, and I want to touch on that first. I mean, maybe just touch on how you became involved in cancer registration and perhaps what your current role is, please, Giske. Thank you.
So thank you, Freddie, and thank you for the invitation and a wonderful talk. So I am a physician trained epidemiologist, and I worked with the cancer registries as either the basis for my research or as the outcome in studies both in the US and in Norway. And so I've been working with cancer registry data all my adult life. And currently I am the director of the Cancer Registry of Norway, which is part of the Norwegian Institute of Public Health.
Thank you, Giske. And yeah, I mean, you have an amazing experience. I know in California and some stellar research and back in your home country, and being the director. One thing you've done in the last years is not only have you been the chair of the scientific council of our agency, but you've also been a reviewer of our scientific work on a quinquennial basis. The last one, 2017 to 2021. I wonder if you can just sort of give a highlight on how you see the importance of our work, I guess, in cancer surveillance, but cancer registration generally, just a view from you.
Absolutely. I think you made a very strong case, Freddie, in your talk, that obviously cancer surveillance is essential in order to monitor the cancer burden and to monitor it over time. And this is important, not just the counts of the cases, which is essential for hospitals and health authorities to plan care, but also to monitor the trends so we can compare ourselves, identify new risks, new exposures, identify how our cancer prevention programs work across within our country in comparison with other countries, but it's also to monitor how cancer care works in our countries compared to other countries. And of course, all this is essential that is based on population-based cancer registries. And when we monitor, so very often when we see that there are some trends that are changing, then we can compare ourselves to other countries and then try and go in and understand, is this because of an exposure that's changing? Is it because of diagnostic advances? Are we picking up more cancers? Are we picking up different types of cancers? And so I think this is all very important to monitor this disease.
Yeah, thank you, Giske. I should have actually presented one of the slides because I love it. I present it a lot. If you go to the Cancer Registry of Norway website and look at their annual report, that you have the trends of incidence, mortality, and survival back from the 1960s up to, what is it, 2023 now? Maybe 24.
24.
24. But just wonderful to look at those per site. I mean, it just shows you the complexities and the value of long-standing cancer registration and mortality data. Thanks for that, Giske. Just onto Europe a little bit, and I did give a little plug. I guess there was a kickoff meeting in September of the Cancer Watch, the European Commission Joint Action. I would say it was a wonderful meeting that you hosted, 150 people. Can you say something about the aims of Cancer Watch? It's a 3-year project, and maybe you can just say more about this important project at the moment.
Yeah, absolutely. I mean, you showed the map of Europe, and you showed that it wasn't completely dark blue. It was both countries that have regional registries only, and also some parts that are not covered at all by population-based cancer registries. So there is a strong need also in Europe to increase the cancer registration coverage. And so what we want to do in Cancer Watch is to help this process. And first of all, we will assess the existing cancer registries and help identify opportunities for collecting data, timely, high quality data. And then we will also assess the quality of the registries and try and identify how can we improve this quality. And then, of course, for these data to be useful for public health authorities and for European lawmakers, we need to be able to publish these data timely and comparable on a European platform. So this is the European Cancer Information System. And what is so important in all of this, Freddie, is that, of course, we use what IARC is providing, which is these indicators that are standardized and harmonized, not just across Europe, but globally. And that really gives us the tool to compare ourselves across countries. And then finally, in Cancer Watch, we want to also get the data on, as you mentioned, survival and also prevalence. And we need to get those on European platforms as well. So we want to have sort of an up-to-date, data-driven platform for cancer surveillance in Europe.
Brilliant, brilliant. Thank you. And you're the coordinator of Cancer Watch. And I'm old enough to remember how the funding from the European Commission has changed. It was the Europe Against Cancer program in 1989, and it was small amounts of money. But I think this is the first time that cancer registries, I know many, there's nearly 60, I think, involved in Cancer Watch directly. Can you say something about the importance of this at this present time? I think you've alluded to this already, but why is it so important for Europe to have this Cancer Watch project now?
Well, one thing is to cover that map, right? Is to get everything dark blue, and there is a strong need for that. And what we see in some countries is that where they don't have national estimates yet, is that they want national estimates. And our desire is that this is based on population-based cancer registries, of course. So many countries need support. So both the ones that do not have this national coverage, but also where we do have that in all cancer registries, we see that there's always this need to show politicians why we're important. Everyone is struggling with funding, and funding for what we do, which is essentially help preventing disease and preventing death from cancer. We're always fighting with everyone else who's trying to get funds for other parts of the healthcare system. And so that's why we think that Cancer Watch will help put the focus on this. And then, of course, in addition to helping with equality and timeliness of the data. But I think this getting the focus on the population-based cancer registries, showing why we're important, I think that's really the key with Cancer Watch at this time.
Brilliant, Giske. Thanks so much. I mean, and as you know, IARC's involved in this, and we're really happy to be involved.
Very important partner. Yes.
Yeah, no, I think it's great. It's great. So we're going to have to leave it at that, Giske, not because I want to, but there's much more ongoing. So, but thank you so much again. It's really good to speak to you, and very much good luck with the registry and Cancer Watch. We'll go with you all the way.
Thank you, and likewise.
Thanks very much. We're gonna turn to our next speaker. And I'll see if I can do this seamlessly. I'm not sure I will. Who's going to be Les Mery. Les Mery is my colleague. He runs the Global Initiative for Cancer Registry Development. I sort of indicated the project. It's not a project, it's very much a program, as Les will tell us. I'm just going to get this on full screen, and I'm going to hand over to Les. I'm hoping this will be in the...
Yeah. Thank you, Freddie. I'll let you do that. Maybe just as you do, just offer a few words of introduction.
Sure. Can you see it in the...
Yes, but I think you're one slide. I don't see the first slide yet, the title slide.
Okay. Anyway, over to you, Les. You can introduce yourself. Thank you.
Sure. Thank you, Freddie. Good morning to everyone. Good afternoon, as you may be around the world. So as you heard, my name is Les Mery. Very happy to have all of you express interest in this topic. And for my part, I'm going to pick up on some of the themes that Freddie touched on, and namely that is what underlies a large part of our work here at the agency. And that is how we produce the indicators, but then also the research, but more importantly, how we support registries worldwide. And for that, really at the heart of it are the staff of the population-based registries and the registries themselves. That's really what the story is and what I'm trying to tell. It's really about them, how we try to support them historically at the agency, and how we've modified that in recent years with the introduction of the Global Initiative for Cancer Registry Development, or GICR. How we can learn together. That's a large part of what we're trying to do with this program. And really, it's about global capacity building so that we can better inform cancer control. And I think Giske really nicely touched on that in her summary or emphasis on the role of cancer registries and how they link to better inform health policies, etc. So next slide, please, Freddie. Or am I supposed to move these, or Freddie, are you there? Okay, great, thank you. So just a quick outline. I'll go through a bit of the rationale, and Freddie's brought most of this forward already. And then spend most of the time on just what is the GICR and how it operates. And then provide you with a few examples of what we call global goods. And these are products that we've been working with, our staff here at the agency on GICR, together with our colleagues in the regions, cancer registries worldwide, thinking about products that really are for the benefit of the whole. And we do this intentionally, and I underscore this point, in a manner that we co-develop these materials. So I'll touch on 3 examples of this that you see there. And then, as was done in the first segment, we'll link with some discussion to our colleague, Anne Korir, who's the principal investigator at our Center for Expertise in Kenya. So next slide, please, Freddie. So some of you may be familiar with this slide. I've probably overused it a little bit in telling the backdrop or rationale to why we developed this program of activity called the GICR. Freddie very nicely laid out the need in terms of the cancer burden and how it extends to particularly low middle income countries. Also underscoring that was the inequity, both in terms of data, available data for decision making, but of course we know that also plays out in terms of outcomes and survival differences, etc. And then more recently, in the past decades or so, there has been some opportunity, thankfully. There's been greater recognition for the need to prioritize non-communicable diseases, and in particular cancer. As you may be aware, there's been several initiatives launched at WHO for breast, cervical, and childhood cancer. And together with the GICR, these represent 4 global initiatives directly targeting cancer efforts worldwide. And so with that, we felt it really gave the opportunity to create some action and in terms of concrete activities, coordination, and efforts through partners to better improve cancer control through surveillance data. And that gave rise to the concept of GICR. Next slide, please, Freddie. So I just take us back, particularly maybe timely with the fact that we're commemorating our 60th anniversary of IARC, and these were some former scientists from our same unit or the analogous unit at the time. As you see here, Calamure and colleague, and really why I bring this up is to say that prior to developing the GICR, we did look back at the history of IARC and what was the intention and how did it operate, and trying to learn from those before us. And really at the core of this was this concept of working directly with registries, ensuring that they have the support they need to produce good local data. It wasn't about just giving something to IARC, having IARC produce estimates. It was really about equipping those in the countries themselves to be able to conduct the work. And as a secondary benefit, there was the aspect of work that connected to the global indicators, CI5, etc. So we tried very much to maintain these core principles, at the same time recognizing the scale of our efforts today and trying to reach the world needed a change. And that gave rise to the GICR. Next slide, please, Freddie. So very quickly, I won't go through all of this, but simply to say the GICR is about a decentralized model whereby we try to take the core support that existed at IARC as described by the past scientists, and now put that in the hands of each of the regions. And we did this firstly by constructing what we call 6 IARC regional hubs. And those are insulated as well by a group we call the Centers of Expertise. And I'll touch on this in a bit more detail. But the areas you see in color, Latin America, the Caribbean, all of Africa, Asia, Pacific Islands, those are our target regions. And predominantly, of course, where low middle income countries are, which is where the need is greatest. Next slide, please, Freddie. And so what are we trying to do through these efforts? Really, in each region, we're trying to act on 4 key functions. The first being training, really provide opportunities for regional courses that touch on topics that are of interest to those colleagues in those regions, and very importantly, led by people in those regions. In conjunction with that, we also provide what we term direct support. So this would be areas where registry may have questions, may have difficulties implementing certain practices, and we try to couple them with other registries in the regions, our hubs, our centers of expertise, or our regional trainers, which I'll touch on in a moment. The third quadrant on cancer control just is really an important reminder that it's not just to produce data or static tables, but really the totality of the effort is all targeted towards providing better information for cancer control actions, in particular national cancer control plans. And then finally, we felt that in order to really embed this as a sustainable program of activity for the future, we needed to ensure that networks were running in the various hub regions, so that peer-to-peer efforts, peer-to-peer support could help to the registries in need and really provide a tangible benefit to those in the region. Next slide, please, Freddie. So this slide just gives you a summary of the structures I mentioned and the map. where you see on the left-hand side what we term our hub regions or catchment areas for where we're targeting. We have in each of those regions a hub that operates, with the exception of Latin America and Pacific Islands at the moment, where IARC itself, our staff, have taken over some of those functions in terms of coordination. And then very importantly, recognizing that each of these regions are too large, both in terms of the scale of effort needed and the needs. We've been very fortunate to have various partners come on in what we term the centers of expertise. So they work closely with the hubs to help support countries. And at the bottom line, you see the summary. So in no way is this a small scale effort. We're targeting 85% of the world, roughly 150 countries. And we do that principally through these 6 IARC hubs and the 13 centers of expertise. Next slide, please, Freddie. So just to touch on this, because we often get a question, what is the difference between the hub and the centers of expertise? I mean, we don't try to dissect this in a hierarchical way in any manner, but simply to say the hub has some additional duties, if you will, in terms of coordination in the region, but very much it's acted upon together with these centers of expertise. So this is one example drawing from what we term the Mumbai hub, which is South, East, and Southeast Asia. It covers approximately 50% of the world population just in this one area of the world. And so for that reason, even having the Mumbai hub plus the associated centers in Thailand, Korea, Japan, and China as well, which is not listed there, my apologies. This still is a very large effort to try to do that. So in addition, I should mention just very quickly, we've also put forward this notion of GICR partner countries. And here in particular, we try to match opportunities where the country itself is poised to go forward, either because of different circumstance, there's suddenly a policy or interest from leaders in cancer registration, and/or direct investment. And in those situations, we try to then elevate our degree of support and prioritize some of those efforts. And in particular, these are where the centers of expertise are more increasingly becoming involved. Next slide, please, Freddie. So to kind of bring us forward with some of this and maybe to make what I've described a little more real to everyone, I'll go through 3 examples of what we term global good. So just as a reminder, these are products or large programmatic themes we have running through the GICR, which cut across all our hub regions. And the idea is that what is produced as a result of this is really for the benefit of those throughout the world. So it's not meant to reside just in one locality or with one registry. These are really cross-cutting, larger initiatives. And so just for the sake of time, I'm presenting 3 such examples. The first of that is our GICR net. The second will be some examples on electronic medical health data linkages. And I think Freddie touched on this, and I think we can all appreciate there's a lot of interest in this area. And in some ways, a lot of demands placed on registries to demonstrate how they've modernized by moving forward and taking advantage of some of the electronic opportunities. So we've tried to venture into this through one large initiative that I'll describe that links the registry to something, electronic health system, the district health information system, version 2 or DHIS2. And just to give you an illustration of that. And then finally, to draw some attention to a relatively new opportunity launched this year, which is a set of self-learning, e-learning modules that are available, that have been created together with colleagues from various regions, but in particular from Sub-Saharan Africa, and with our hub in that region and the AFCRN, African Cancer Registry Network. Next slide, please, Freddie. Okay, so the GICR net, firstly, and I make a point of emphasizing this, it's not a train-the-trainer model. I think we really wanted to evolve away from that, this sort of didactic mode where sort of one so-called expert stands up and pontificates to a group of pupils who then go on. There's merit in that approach, of course. I'm not trying to dismiss it, but in our case, coming back to the principles of the GICR and how we wanted to support and build sustainability, we really felt it was important to change this construct and make it one where we co-develop. So instead of one expert, we have a group that leads the topic, if you will, putting forward some initial ideas on training and the needs. But then we call together through a selection from the hubs, the centers of expertise, various people from the regions that are then invited to co-develop. So in other words, they're fully part of the development of the material, providing insight, intellect onto the topics. And then, of course, thereafter, once created, we call upon these trainers to then go and help deliver and promulgate the knowledge in each of the regions. So this is done directly through training courses, but then also, as mentioned in one of our functions, the direct support to registries. Next slide, please, Freddie. So I think I touched on this already, but just to maybe re-emphasize the two main objectives. So the first is to develop a network of trainers. So we do this by subject area. So I'll have a slide that gives you a summary of the subjects we have to date. And as we do this, I mentioned the co-development of materials. So what this means on a practical level is that we create a common set of facilitated slides where each of the trainers from the hub regions around the world can then utilize in their training. And of course, we encourage the adaptation of those materials to meet local needs. And in many cases, that includes translations to various languages. And the second aspect that we call upon this network for is to support registries in the hub regions. So maybe if you think of two static moments where course 1 and course 2 on a particular topic, but in between registries might get stuck and a host of other areas they may need help in. And so that's the role that we're trying to cultivate here, is to have these trainers become a resource to the registries and that they're not left alone. Next slide, please, Freddie. And this is just one depiction of this. Why I show this, I really like just the instant feeling it gives me in the sense of the globalism of what we're doing. So this is one of our what we term our GICR net, or one of our networks focused on the topic of data quality. And here what you see represented, I think it's about 20 or so individuals, but they come from all of our hub regions, 20 to 25 individuals, and they come from worldwide, and they've been really instrumental in helping to help registries throughout the world. Next slide, please, Freddie. And this is just one more example of that. Actually, a colleague of Anne Korir, Gladys Chisumbi, who's at the Eldoret Cancer Registry and also affiliated with our Center of Expertise there. And she's helped support, particularly, she's one of our GICR trainers on CanReg, which is a software, and she's helped train. And through this effort, we can reach many more people. And if you imagine that multiplied out by 20 to 25 times. So rather than having one individual at IARC, which was the previous model, try to support all of these countries. Next slide, please, Freddie. This is just a summary then of where we stand today in terms of the network. So to date, we've set up, 6 networks under the topics you see there, ranging from CanReg, which was the earliest, and then very recently, we had one on registry assessments. And so this has produced approximately 140 trainers, which you can find on our GICR website. And they're really focused on the specific subject, but then also methodological methods behind those. Next slide, please, Freddie. Okay, so just moving quickly, maybe I'm running short of time. My apologies. So the second is this link to electronic innovation, or what we call the Innovate project. And so we try to enter into this world and in a way that could provide maximal benefit to registries. And that first point of entry was through something called the DHIS2. So for those who may not be familiar, this is health information system developed at the University of Oslo, used widely throughout the world, but in particular in Africa, Asia, and parts of Latin America. And what we tried to do here was through collaborations initially with the Rwanda National Cancer Registry, but then taking the power of the model of the GICR, we took their work in Rwanda, where they built an initial cancer module in DHIS2 to in essence, replicate the work of the registry in terms of ensuring business rules, etc. And then we piloted that in the Caribbean region. And that all is leading towards a product that will be forthcoming in the winter and spring of next year, where we'll have a global installation package ready that countries from around the world can use. And when they use it, the idea is that we actually take the knowledge from each of these groups and try to better it for those who are looking to use the tool later on. So this is very exciting work for us, and I would just say for those interested to stay tuned. This is forthcoming. Next slide, please, Freddie. And then this is just a little more of what I discussed, and that in fact the concept is that we know that in some countries they are using DHIS2 as a primary method for collecting data and for housing electronic data. So the idea was that we could work within that system and have it compatible with the registry, so that those hospitals or systems users who are already familiar with it and who are mandated to use it would only have to enter the data once. They entered in DHIS2, and then it would be transferred to the registry and sort of to complement. It's not intended to replace the registry, but to complement it in terms of an additional data source. Next slide, please, Freddie. And I think this is where we end. So just very quickly to say that some of you may be interested or may not be aware, but we have recently launched what we call the GICR e-learning series. And this packages together a lot of the knowledge, a lot of the courses we've been running. I would even say historically at IARC on the topic of basic cancer registration, everything from what is a registry through to coding, data collection, data quality analysis, etc. And so this is now available freely online, whereby individuals can register, take the courses at their own pace. Within each course, there's a set of exercises and also resource material available for further reading. And then finally, one important aspect is that we introduced the notion of degree of certification. So those who complete all 15 modules within a 12-month span would be certified as a global cancer tumor registrar. I probably got those acronyms wrong, but there is a certification in essence just to recognize their work. Okay, next slide, please, Freddie. I think that was it. Yeah. So that was just a very short introduction on the GICR, but to bring this forward a little bit more, just as Freddie had in his segment, we're going to turn to our colleague Anne Korir, who's operating high-quality cancer registry in Kenya, and actually is the principal investigator of our Center of Expertise coming from the Kirby Institute in Kenya. So welcome, Anne, and hello to you. So just as was done with Giske, we've prepared some questions and just would like to table those to you to get your perspectives.
Thank you, Les. Thank you. I'm pleased to be here today.
Very good. Well, pleased to have you. And I should mention that not only in this work, but you've really been a foundational partner in the region for a long time.
Thank you.
So can I begin just to say, can you maybe offer a brief description or a brief history of the cancer registration in Kenya and how you became involved in this work? Yeah.
Yeah, thank you, Les. So so first of all, my name is Korir, and I am the head of the Nairobi Cancer Registry, which is based at the Kenya Medical Research Institute. So KEMRI is an agency of the Ministry of Health responsible for research and capacity building in research for human health. I became involved in the registry just at the inception of the Nairobi. The registry began as a project, pathologist, and they needed a technical person to registry, and that is how I was attached to work on implementing the study. And so we began the Nairobi as a study, and of course, we received so much support from IARC, WHO, US National Cancer Institute, and many other partners, the Ministry of Health, Kenya. And we began then to do the work, and with guidance from able then to package the registry as a population-based registry, county of Nairobi. And over time, we have had many other registries established. We had the Eldoret Cancer Registry that started in the 1998, which was immediately followed by the registry in the year 2001. But prior to that, there were other hospital-based systems that were being put together by clinicians in major hospitals. But I would say the organized registries really began around this time, 1998 and 2001 at KEMRI. And we've had initiatives to really build capacity across Kenya and across the region. So that is how I began involved. And in we realized we could not run the registry as a project, and a request to the board of KEMRI, then the registry was established within the institute, and it was made a department within the Center for Clinical Research. This department since then. Thank you.
Oh, thank you, and very, very insightful answer. So I think you shed a lot of light, and it is sometimes the story of how registries began under sort of a research basis.
Yeah.
You've been successful in growing that, you and colleagues, and I think one important part is that you're now sharing what the knowledge you gained with not only those in Kenya, but throughout the region. And that really is the essence of the GICR and what we're trying to establish. And I think you embody that so well. Maybe moving to our second question. So I talked about the IARC hubs and tried to give some description of those, but has the existence of the IARC hub operated through the African Cancer Registry Network in your region? Has it changed the way countries in the region receive training and support from the time where it didn't exist? And if so, how do you feel that has happened?
Yes, there has been really a lot of improvement since establishment of the IARC hub, which in sub-Saharan Africa, it is the Africa Cancer Network. And as you know, we started this network way back in 2012, few registries, but over time, it has grown to over 35, 25 sub-Saharan African countries. And so there's, since we began this more organized kind of training, I think before that, ad hoc, one-off trainings, not well coordinated, but establishment of the AFCRN as the hub for the Africa region. And then in the recent past, also the centers of expertise and in South Africa, we've seen really more organized, things well coordinated. We are now offering trainings, technical mentorship of registries in the region. And we've had many, as you said in your slide, sort of regional trainers that can offer this support more closely. Maybe one person responsible for the entire region. We have experts in various areas, Reg 5. We now have the DHIS 2. So if a registry is probably interested in that, we know who can mentor them to get that kind of support. We more standardized material for training, which is, standard across, the we use in Nairobi will be the same as what is used in, other registries in the region. So that kind of more organized kind of training and mentoring has really seen a shift in how we do things in the region. And we're seeing more improvement in terms of quality of data that is being generated, timely kind of support. When we started the GICR Center of Nairobi, some registries were still using CANREG 4. And so support them to move to CANREG 5. So we see that there's really been the establishment of this more coordinated way of doing things. We have now the e-learning module that you just presented, and registries can be able to access relevant training, working on their own pace to really understand the concept of registration. And then as the centers of expertise, you're able to mentor them more to really understand these concepts and apply them in their registries. Seen introduction of, like essential TNM in order to improve gaps in the registry. Like we have had in terms of staging, where you find that this data is not well documented in the clinic. And so introduction of essential TNM is also going to improve that. So we'll have more complete data that can be used to inform cancer control to improve research. So I think that we have really seen more improvements since the establishment of the hub and the centers of expertise.
Yeah. Okay, thank you, Anne. That's really nice to hear. And I mean, I think that was the idea behind what we were after, and it's nice to see that put into action.
Yeah.
Maybe on a related note, I mean, as you pointed out, implementing population-based cancer registries has improved, certainly in sub-Saharan Africa, but we know it's not uniform, it's not everywhere, and that there are still some struggles. But maybe you could comment on, have you seen a shift in ministries of health in terms of better understanding the need for cancer registry data, in their importance of local data, these type of things versus, a sort of model data or global can and other estimates? And within that, do you have any sense of what is working and what has happened or what more should be done with respect?
Okay. Yes, Les. I believe that there has been a shift in the way the ministries of health perceive cancer registration. I think previously there was limited knowledge on what are these cancer registries, how are they useful to the ministry. But over time, we've really seen a shift in how the ministries of health perceive registries, not just in Kenya, but in the region. In ministries, involving the cancer registries in the activities they're doing. We have seen that even in the establishment of the national plans, the ministries of health reach out to cancer registries to be part of that. If I can give an example for Kenya, in the last two subsequent national cancer control programs, plans, the ministries of health involved the cancer registries, as part of the technical committee that is generating the plans. And if you see the plan for Kenya, you will find that an input from the registries that came up with the plan or the roadmap of what to do in the next 5 years. So I see that the ministries have really understood the concept of population-based registries and how they're informing cancer control, in informing policies that they are generating, often engaging the registries in the things that they're doing. They've also gone ahead to even establish technical committees. Like in Kenya, we have a technical committee that is responsible for cancer surveillance, cancer research, and the staff from the part of these technical committees. And this is not just happening in Kenya, we've seen it in Rwanda, we've seen it in many other countries. So I think there's really been a shift in how ministries perceive registries. Of course, there are still many challenges, but I think how do we improve that? I think continuous engagement, continuous advocacy to really raise awareness on the importance of these registries and the value they bring in cancer control. I international partners play a big role. Whenever we have like a call by WHO, for example, or IAEA going into a country to do an assessment on cancer control programs, if they bring out the issue of registries as an important aspect of cancer control, then ministries of health begin to realize the importance of these programs, or the importance of, having registries in place, and they begin to work towards supporting the registry. And I know that funding is still a challenge less, but ministries can offer support even in ensuring that the registries are able to access data. We have seen challenges where registries are not able to access data, maybe in private hospitals, civil registries of death. If the ministries of health are involved, then they can be able to facilitate that, so that registries are able to generate more quality data, more complete data, and just reduce the many barriers that they are facing in accessing data. So in my perspective, we have seen a shift, and we are very to the ministries of health and how they are involving registries, how they are engaged, and even using their data that they generate to inform cancer control programs.
Yeah, thank you, Anne. I mean, that again is very encouraging. And I've always thought of this as the kind of so what, when a registry presents data, there has to be a so what that grabs sort of a relevance to the decision makers. And it seems you've managed to bridge that. And as mentioned through GICR, IARC, we're trying to study these models and make sure we can identify best practices and share that throughout the world. And maybe final question, if you could maybe respond briefly, and you've touched on this already, but how do you see registration in Africa changing? Are there some areas that you note for ripe for innovation and opportunities, and maybe, what might be some of the challenges ahead? If you could just briefly touch on that topic to end, please.
Okay, yeah. So a lot of improvement in registries because of these more collaborative efforts that we currently have. And I think as long as we strengthen that, then there's going to be improvement in the kind of data that we are generating. I see that registries are aiming for high quality data. A lot of registries, aspire to have published in cancer incidents in 5 continents, and they're really making a to ensure that they are able to generate high quality data. So I see that over the years, we will have more registries publishing their data, and also ministries of health utilizing this data to in programming. I see that in future, we will be adapting newer methods of collecting data. I think timeliness has been an issue in most of our registries. We are late, maybe 2 years, 3 years on the data that we generate, and this becomes a concern from the ministries of health. Want more timely data to inform their programming. I think the opportunities that exist include, one, maybe adopting new, maybe adapting, digital platforms of their data. We have talked about Contract 5 and how we can make it system where registries then can be able to collect data directly from the into maybe tablets, and that data is shorter time as opposed to the current paper-based system where you have to fill out case register forms and then have another team to do the data entry. That really creates a lot of delay. So, so I think the opportunities include, shifting to more digital systems of collecting data. Dr. Freddie Bray talked about AI and natural languages, where you can have tools that can extract clinical data from the medical records or even from the pathology reports. That will really reduce the amount of time that we spend to collect this data. So I think these are opportunities. You've talked about the innovate, and I think this is something that many registries are embracing, because there's a challenge in terms of person. Human resource is a big challenge in most registries. So if we can be able to utilize the existing human resource in the facilities or in the hospital, assist in the collection of this data, then it will also reduce, the of this data. So, these are, I feel if we continue to work together, we can improve on, and that would make us really progress in how we collect the data, in how we package and even utilize this data for cancer control and also for research. I see an opportunity where more registries will be generating research output from the data that we collect, so that the data is not just and stored in the computers, but how do we utilize this data to really inform research questions that are relevant in our communities. The GICR e-learning platform is really a very innovative undertaking that is going to assist us in delivering this material to registries, working at their own pace to really learn and understand the content of registration. And I think this is going to improve the quality of data that we generate. In terms of challenges, I think we continue to experience many less in this part of the region. Sustainability is a big concern. Really cognizant of how do we address sustainability issues. We have seen registries in the region that are doing very well, but the moment there is funding from the donors, the registries go down. How can we get the governments in Africa to invest in cancer registries and to sustain cancer registries? I think those are conversations we need to have with our leaders, with the government and to see that registries are more sustainable by having more human resource, more permanent staff within the registries, having resources like a budget line to meet the costs of the various activities that the registries undertake. I think there's a misconception that registries are registers. This is a misconception that we need to address, in my view, that registries are not just registers, they're centers that are really mandated to do so much, and they require resources, they require infrastructure, they require personnel, expertise in cancer, biostatisticians, data managers. And so if ministries of health and general understand this concept, then I believe there'll be more support to the registries from our governments. We also need to address the legal issues. Less legal issues are becoming a big challenge in our region. Data protection laws used, and navigating that challenge. So maybe we also need the global community to come out strongly to say yes of these laws. They need to find a way of having registries access the data so that we are not having challenges of incompleteness data that we generate.
Right.
Thank you, Les.
Well, thank you so much, and we need more advocates such as you, and we know your efforts have gone a long way. Thank you so much. We're going to turn back, I think, is it with Freddie or Isabelle to hand over? But thanks again, Anne, for your insight.
Thank you, Les.
So thank you so much, Freddie, Les, Anne, and Giske. Those are all really, really interesting talk, and I think also really foundational for what I am going to briefly now present, which is then the research work within our cancer surveillance branch. And then I will be then discussing afterwards with Professor Karen Canfell from Sydney on how then we use the data and translate that really into action, into policies. Next slide, please, Freddie. So if you can click until the end, Freddie. So just to give a bit of a vision of what we intend or aim to do, Freddie already mentioned this, but the idea is then to use the data, the knowledge, the collaboration with local stakeholders such as Anne or Giske to provide evidence for planning and evaluation of programs across cancer control spectrum. We, of course, focus a lot on prevention as that is really then the heart of work at IARC. While doing that, we also then strive to bring in innovation, bring in the state of the art in terms of methodology in our work in descriptive epidemiology, and then by doing that, what we would also then like to do is increasing our outreach. We're not only going to touch academics or research, but we want to work more, and we want that the data that we have is then to be used by all stakeholders in cancer. At the end, the idea is to accelerate impact on cancer control and then increase the speed for which then we can reduce burden of cancer globally. Next slide, Freddie. So in doing so, we have done, this is really a very brief summary of what we do, but we do a lot of descriptive studies describing then the burden. And then I will show you then later on some of then the research that we are doing, which then I listed here, which is then informing resilience or health system resilience. How do we work around creating new global indicators, how we transform the data into then information for prevention, and then also then looking into cancer survival and some of then determinants of cancer survival. Next slide, please, Freddie. So population attributable fraction, this is a research statistical term, but in essence, it is a calculation on how large is the proportion or contribution of risk factors on cancer burden. We've been doing this at national, at regional, but also global level. We continue to expand the risk factors that we are including in our Global Cancer Observatory, where you can find this information in cancer causes. And then we don't only want to stop here by providing how much smoking, alcohol, and other risk factors impact global cancer burden. We want to be able to use this as well to plan for future prevention program. So this, we're using it really then as baseline for prevention. Next slide, please, Freddie. Just then to give you a few examples, this is a project that we've done with over 60 collaborators, stakeholders here in France, where then we put together all the data, local, national data that's available to estimate the proportion of cancer that can be then linked to different risk factors, as much as risk factors that we know established as causing cancer. If you see then the graphic here, that we use that methodology to estimate then the proportion of cancer that are preventable in Europe. On the top, you see then the cancer types for which prevention have then a big impact. So there's a large value of prevention, for example, lung cancer, where then 86% of all cancer cases can be prevented. We can immediately guess what are then the causes. And then on the next line, then where then the cancer that are then linked to risk factors and somewhat lower. And to those very small cancer sites, if you see then the size of the bubbles, for which then the impact of prevention is somewhat lower. It really then shows the magnitude for different countries, for different cancer, but also then what and which area of risk factors prevention we can do. The newest, as I mentioned, and Freddie mentioned this as well, the newest estimation has been done on skin cancer, looking then how UV and UV sun-smart programs can actually have a big impact on skin cancer globally. Next slide, please, Freddie. Then we use this, as mentioned, then to estimate future burden. So this is an estimation, a modeling, where then we modeled the impact of generation-free tobacco control program. So if we were to ban the sale of tobacco, and then the young generation of today don't have access, don't smoke, you see then at least 1.2 million lung cancer deaths. This is then 40% of all lung cancer can be prevented in this young population. We give also then the data by region, by country, of course, for country to look at it, but it also then shows really interesting results. For example, in Northern Europe, such program will then have a big impact on women, still big in men, but then you see then there is then that women generation that's starting to speak up smoking, and similar impact you see in Northern America, for example. And then the other way around, you see it with Northern Africa, where then male will be then impacted more. Next slide, please. So then with that information, we're developing novel, new global cancer indicators. That's then within the line that we want to reach out larger group of stakeholders. And what I'm going to show here next is then our most recent result, which is then on productivity loss, where then you can then calculate or look into the impact of societal impact of early death from cancer. So this is then a paper that is published by one of our PhD students here, Stella Kong, who calculated the productivity loss of cancer. So productivity loss is then when someone is diagnosed with a cancer, that person stopped working because of the disease, died earlier because of cancer, and then this has a big impact on the society. If we calculate it and try to give an economic value to this, it is then more than 500 billion of US dollar lost to early death from cancer. This sounds really big, but this is just to give you an idea, is a national GDP or income of Thailand. It's a whole country income that is lost because of cancer. And this is happen at annual basis. So there's a lot more to prevention than only preventing cancer suffering, cancer death, but a whole also impact that can be prevented in the societal at large. Next slide, please. The other work that we're doing is then on survival, not only to pick up data, but also then improve data in the ground. So this work on SurfCan, that we call it, is a big collaboration with Cancer Registry and with GICR. Survival is really important to show how cancer control in countries are effective and efficient. And then this is a data then from cervical cancer in different countries, and you see a wide variation in survival. This is injustice and unethical health system can be improved. As you can see, countries can achieve a better survival for their patients. And then having this data can really then inform progress in cancer control in general. Next slide, please. And this is then going to be my last then few examples, which is then for the initiative for resilience in cancer control, a work that we do a lot within IARC. So this is then a project that we co-coordinate with Karen, that was born during the COVID period, which is then to look into then the impact of disruptions on cancer services. Next slide, Freddie, please. You then see then the results here. For the first review, we included then more than 9,000 data sets, and showed that during the COVID period, that disruption has caused 50% less women who were supposed to be going to screening didn't get to screening. And then if you see in terms of treatment, 29% of patients who were supposed to be receiving treatment didn't receive cancer treatment. And our response to this, in addition to giving data, is also then trying to provide a tool. So next slide, please, Freddie, which we call the cervical cancer elimination planning tool. And then I'll talk to you all with Karen, then hopefully then going to explain and tell us a bit more about this tool. So Karen.
Hi, Isabelle. Can you hear me okay?
Yeah, I can hear you really well. Before we're going to our tool, but then to our tool, hopefully for everybody here in the audience, but for everybody in the world, the tool is available for free. Can you tell us a little bit more about yourself? How did you come to this work?
Sure, and thank you, and just to acknowledge what a pleasure it is to be at this webinar, and to thank all the other presenters. The work that IARC does in cancer surveillance is so critical and so important, and it's a fundamental for countries in terms of thinking about documenting and then thinking about reducing the burden of cancer. So I have worked with IARC actually for many years. Our team is now at the Cancer Elimination Collaboration at the University of Sydney, and we work across cancer types. We use a modelling lens, and it's been a wonderful collaboration with IARC because it's data meets predictive modelling, I think, in our collaboration. Our flagship program of work has been in cervical cancer and in work that has informed the elimination strategy, which was launched by WHO in 2020. And in fact, it goes back to a discussion that Freddie and I had back actually in 2011, where we really had a discussion about how it was really important to use the global data to inform simulation of what was possible in cervical cancer control. That was before we started talking about elimination, but we were really needing to understand the predicted combined impact of HPV vaccination as it was rolled out globally, as well as the potential for cervical screening and eventually as well the potential for treatment. So with Freddie and then with Isabelle and team, we were able to really, I think, combine our strengths, and we did a really important global modelling study together of the combined impact of HPV vaccination and cervical screening, which was published in 2019. But I think that study really informed then when WHO then called for action towards cervical cancer elimination and assembled a fantastic consortium, which became known as the Cervical Cancer Elimination Modelling Consortium. We had a template, which was the combined work that our team had done with IARC based on the best available data. And then that was expanded upon by the consortium and used really to support the estimates of impact of scaling up access to elimination, the plan for elimination, and the definition of the goals for 2030, which are now known as 90-70-90, that 90% of young girls will be vaccinated, 70% of women will be screened with HPV at least twice in a lifetime, and 90% of women that require pre-cancer or cancer treatment services will be able to access it. So that modelling exercise, which was founded in our collaboration, I think has been absolutely critical to understanding the impact, and we estimated from there that 62 million lives could be saved through scaling up to 90-70-90 in low and middle income countries. But also, as you mentioned earlier, the economic case is really important. So that evidence was also used as the basis for estimating an ROI, return on investment for countries, which is a very, very positive return indeed. So I think the whole collaboration has been incredibly important. Again, it is founded in data and evidence from registries. Thank you.
Okay, that's really nice to hear. I mean, sometimes you summarize this so well, but we discussed now, you mentioned a little bit on the importance of data, and you use a lot of modeling in kind of then to inform policies. Can you tell us just a little bit, because modeling is very scary for most people, including myself. It's a scary word, but how is it? How does it work? And then it would be nice then to hear how does this then implemented to the EPT, so the elimination tool. How does modeling work, and the data, cancer registry data, for example, where does it come in?
Yeah, it's a great question, Isabelle. So I think our team is very specialised in this space, and we've actually developed over, in fact, 25 years now, a major platform which is called Policy One, which has now been applied to many cancers. And essentially what we're doing, we're trying to capture risk and distribution of risk for a particular cancer at a population level. So when we're talking about cervical cancer as an example, we're looking to capture exposure to the causal agent, HPV, in a population, capture the dynamic effects of vaccination, capture the system of the effects of screening and treatment. And these are really detailed platforms that require a lot of data to calibrate, and we really spend many years actually in improving these platforms and testing them against new data sets in a process called validation. So data and large scale data is absolutely critical to their operations. So in terms of the global modelling that we've done for cervical cancer elimination, it's really been, with IARC's engagement, has been really connected into the GloboCan estimates and into registry data, which has been absolutely critical. So those fundamental, I think, to the WHO cervical cancer elimination strategy is the estimates of impact, and that's completely grounded actually in GloboCan. So I think it's really important to understand that. Mm-hmm.
Yeah. And then my final question, Karen, we are now using these models live. Can you give us a bit of a story or example on how we're using the elimination planning tool or this model and this data live in countries, and how it can be used and to shape policy?
Yes, well, I think you showed a slide earlier, Isabelle, of the elimination planning tool, which has been actually sort of a wonderful example of the collaboration that we've built through the cervical cancer work and also through IARC, as you mentioned. And I think what this tool does is it brings the power of this very complex modelling to countries and to policymakers within countries, and also, in fact, to civil society advocates and to consumers and the community in countries. So the idea with it is really making the data available. So it's a tool where anyone can kind of select the scale up that they think is reasonable for vaccination, screening and treatment. And from there, get those estimates of life saved, elimination timing, and really key as well, return on investment for a particular vaccine price or a particular HPV test price. So the whole idea here is that we're really trying to empower countries to have the information, to build the investment case, to make sure that return on investment is tapped into reasonable prices as we think about global procurement and so on for both vaccines and tests. So it's about empowering countries. And I think the elimination planning tool is a fantastic tool, but I think its use is being increasingly embedded in broader programs. So we are looking, for example, in collaboration with IARC and UICC to soon launch a major community of practice for the tool so that users can come together and work through an eco-type platform supported by UICC to work through case studies and examples of how the tool can inform policy and planning for elimination. But also it's been central actually to a major elimination partnership that we're involved in, which is called EPIC, the Elimination Partnership in the Indo-Pacific for Cervical Cancer. So this is a big, a huge program which has been supported by philanthropic support through the Minderoo Foundation and also through the Australian government. And that is now supporting many countries in the Indo-Pacific region to really plan and scale and implement both all of the three pillars of elimination, supporting vaccination activities, supporting implementation of HPV screening on the ground, and supporting scaling up access to pre-cancer and cancer treatment services. And so the elimination planning tool is central to this, and I think will continue to be. We do see it as a living tool, and we'll be looking to improve and iterate it as we go. So I think it's core that we, I think, really, as we're researchers, but we're also implementers, and we're there to support countries. And the tool is actually, as I say, to bring the power of that data to countries as they plan to really scale up in this way. So it's so far been very successful, but of course a long way to go in terms of supporting countries to scale up to actually eliminate cervical cancer. But I think the tool is helping to drive the investments that are coming in and the energy, I think, for elimination, which we're seeing in many countries.
Thank you so much, Karen. And I think that last word sentence you said, bringing the power back to the country is what we all aim to do here also then at CSU. And we hope then to continue this collaboration. For those who are online, look into our tool, but also then in Global Cancer Observatory in general, there's a lot of data and really tool to help country, to help you or to help research. And then now I'll give the work back to Freddie. Thank you.
Brilliant. Thank you so much, Isabelle, and thank you, Karen. And I do remember the time we met, Karen, back in 2011. That's great. Great you have that memory. Yeah, just thanks again. Well, thanks to Isabelle and Les, of course, from the team, but particularly to Karen, to Anne, and to Giske. And I know Giske's had to run, but we're slightly over time. But it's just fabulous to hear your comments and wise words on how we can actually build cancer surveillance, cancer registration, cancer research. And this principle, I think, is inherent through all those conversations we've had this morning. It's based on this foundation of high quality data on the ground, and without that, we really are blind moving into sort of any sort of dimensions of cancer control and cancer research. So this is critical, and this is why IARC and WHO are really trying to sort of build cancer surveillance from the ground, and that way we can make these compilations, such as is disseminated in the Global Cancer Observatory, the impact of some of the research that Isabelle has outlined, and I think this is critical to our work. We had some wonderful, nice comments in the chat. I'm not going to go through the questions now. I think we've kind of run out of time, and but what I will do is go through some of the questions online now. There's some very interesting ones on hospital-based registries and their intersection with population-based registries. How we work with registries in areas and countries of where there's conflict ongoing or of recent. These are sort of interesting questions, the funding issues and transitioning countries. I'll go into the chat and respond to those personally, but I don't want to take up anyone's time anymore. But thanks again to our interviewees, fabulous. Thanks again to Les and Isabelle for the insights from our own work, and thanks to all of you being part of the webinar. I hope it's been interesting to you. Sorry it's been so long, but I think there's a lot that are out there. Please do get in touch with us at IARC. We're very, very willing to collaborate, and this is the whole principle of the talk we've just had. It's all about the power of partnerships. We can go so far if we have this in place. I will stop there. Yasmin, any last words from you, or are we set to go?
Again, just to conclude, thank you all for joining us today for the first IARC at 60 webinar. So after focusing on data as the cornerstone of cancer research, we'll continue our webinar series on 19 November with a session dedicated to discovery this time. Just before you leave, we kindly invite you to take a moment to complete our short satisfaction survey, that you can find in the comments. My name is Soerjomataram, send it to you. Your feedback is greatly appreciated, and we look forward to seeing you again as we continue celebrating 6 years of impact innovation and IARC. Thank you so much.
Thanks, everyone.